Welcome to the LowCarbMD podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor.
Hello and welcome to the Low Carb MD podcast. Guys, we have a really special person here today. Somebody that, this guy, his name is Jason Fung. I don't know if you guys ever heard of him, who comes highly recommended from him. His name is Dr. George Condrut. Am I pronouncing that correctly?
Condrut.
Condrut. Okay, perfect. Dr. George Condrut. And he is, he has a very interesting career. He started his career, his education in biochemistry at the University of Ottawa. He went on to medical school and did his family medicine residency, and he's board certified in family medicine at the University of Ottawa as well. And he is a fellow low carb and fasting and keto proponent. So welcome to the Low Carb MD podcast. We're happy to have you here.
Thanks, Tro. Glad to finally meet you. I'm a longtime listener to your podcast, so it's a real honor to be on here.
Yeah, absolutely. So we were just talking before we went live, but I wanted to capture it. How did you get in? So, I know what it's like to be trained in, I'm internal medicine trained. I know what they teach us in terms of in primary care about nutrition. So all this fasting stuff and low carb stuff, this is not what they taught you. So how did you find your way going from a, family medicine doctor to, wait a second, maybe there's something to fasting and low carb?
So it was little by little. It was. I saw some patients that did keto and did very well. And this was back in 2018 or so. I was curious about this idea of fasting and keto. I read Dr. Fung's book, The Complete Guide to Fasting, and sort of put it in the back of my mind. Then I started listening to a lot of podcasts like your own, like the Diet Doctor podcast, and then the Peter Attia podcast as well, back in 2018. So it became, I became curious about it because I thought, the teaching I was getting was diabetes is a progressive disease. It's irreversible. Same with obesity, aside from gastric bypass. There's not much you can do to reverse it. And yet, I saw people that, I saw one patient that was on 200 units of insulin. And then she underwent gastric cancer surgery and lost a lot of weight and went off all the insulin, including the metformin. She reversed her diabetes. She did very well with the cancer. Then I was looking, my personal life with my dad. He was a type 2 diabetic on insulin, and he was told that he had type 1.5 diabetes, which I was kind of curious about. I didn't know what that meant or why they would tell him he had that. I looked through his blood work. He didn't have antibodies to pancreatic antibodies or anything, and he was just on insulin. No metformin, and every time I saw him, he gained more weight and he was on more insulin, and he kept telling me he's eating sugar-free cookies to keep his sugar from going too low, and I kept telling him, carbohydrates are sugar, and it never seemed to really stick with him. So this all sort of came to a head back Christmas time, 2018, 2019, when I sort of sat him down and I told him everything I was learning about fasting and insulin resistance and so on. And, he went low carb, he went off his insulin, he lost 55 pounds. So I saw it firsthand in my dad. before I started to sort of talk to my patients about it to some extent. And
So
yeah.
I'm just curious here. Okay, so you're exposed through a patient, you see it through a patient, and this is 3 years ago. You had read a little bit about fasting, so you kind of had some concept of it. But then your father's diagnosed with, it's called type 1.5. It could be called late onset, LADA or MODI, maturity onset diabetes of the young, or it's also called flatbush diabetes. There's this area nearby actually that's the flatbush diabetes is one of the first whole area of Brooklyn where everybody has type 1.5, very low
Really?
insulin production. And so your father gets this, you see him gain weight and you're like, we can't keep doing this.
Yeah.
Right. So
Yeah.
and so now you're probably learning about it, about different approaches. And that was right around the time, I think 2019, when the ADA changed the guidelines, right?
Mm-hmm.
So,
Yeah.
I mean, how did you go about finding information to help your dad?
So again, it was a lot of my own research and reading around it. He had tried, sort of crash diets, like hypocaloric diets in the past, and lost weight. I mean, prior to this, I was advising my patients to, watch their sugar, watch their carbs, and eat small, frequent meals. So the fasting part, the time restricted eating, the intermittent fasting part, really was key to what he did and how it worked for him. And I'd be talking to him, texting with him all the time, and as I say, like he went off his insulin right off the bat because his sugars were low, they were normal, right? So
you looked into it, and when you did your own research, I mean, where did you turn to? Did you, like, I remember going back to the primary literature, and looking, what diets work, what has the best effect on A1C, and where did you get your information from? Because I know that if you open up Harrison's, I don't know, I may have sold Harrison's, but I'm looking to see if I have it nearby. But if you have Harris, if you open up Harrison's, it doesn't really talk about carbohydrate restriction. So, but it is in the primary medical literature. I mean, where did you go to learn about this? Yeah.
Well, that's the problem, right? Like, it's not in medical education. It's not in the the continuing medical education conferences I go to. There was one talk that I attended at one of these CME events where they sort of they put the seed of doubt in my mind about the whole fat is bad hypothesis. They talked about Ansel Keys and so on, and it sort of, this was, I think, 2018 as well. It sort of blew my mind. Like, I didn't know that there was this other this other interpretation of the data, right? So that put the seed in my mind. Then I saw my patients. I saw a patient, he did keto, he lost all this weight, and I thought it makes sense, like, why, where are the dangers, right? So I was always thinking about that as well.
So, okay, you're looking up the dangers. I almost did the exact same thing. You go to the literature, maybe you see slightly increase, or you see in the acute setting, higher urine electrolytes. Think about, kidney stones, and what to do that. You look at the literature that higher fat diets may be associated with slightly higher LDL. So how do you go, like, what do you, I mean, you strike me as an evidence-based guy. So how are you gathering, I mean, look, if dad's going to go on this diet, I'm sure you want to make sure it's, not going to give him kidney failure and ketoacidosis and, kidney stones and, heart attack, right? So how do you, I mean, I'm just trying to understand, what happens, what happens there?
No, I mean, it's funny. I wrote him a little a health plan. Even back then, you know, I said, look, this is what you have to do. You have to talk to your doctor. You have to get them on board. You have to adjust your insulin. You have to try and get back on metformin. You have to check your labs. I mean, I didn't really want to, you know, take over his care, obviously, right? Like he's got his own doctors and everything.
But they don't know anything about low carb eating, I'm sure, right?
They don't. And his doctor was astounded. You know, he gave him a big hug when he saw him after he lost 20, 30 pounds. He said, you know, whatever you're doing, keep doing it. So, you know, yeah.
So that must have been a big, so now you're, okay, so he comes off of insulin, he's losing weight, and you're looking into the literature, making sure it's safe for him. How do you go from practicing, now you've seen this, right? You saw that, you mentioned the patient with gastric cancer, your other patient who lost weight, and your father now off of insulin or coming off of insulin. How does that translate into how you care for your patients and your practice?
Yeah, so you know, prior to this, I was telling them to watch their sugar, watch their carbs, if they had diabetes or obesity, and to eat frequent meals, you know, large meal, small meal, alternating like that. And I went from that to telling them to extend their overnight fast, to make sure they're not eating before bedtime, at least 3-4 hours, and to extend the fast after they wake up. So push breakfast back as far as they can, you know, have that fasting, overnight fast, at least 12 hours, if not 16 or 18. And that's simple advice, you know, again, with being mindful of sugars and carbohydrates, but that simple advice of doing time-restricted eating basically resulted in me seeing my patients come back, you know, a few months later, 3-4 months later, and telling me, oh, I did that. It was hard for 2 weeks, but I lost 20 pounds. I lost 30 pounds. And this was happening once or twice a week. And I just couldn't believe it. You know, first of all, I couldn't believe they were listening to me. And secondly, I couldn't believe that advice had actually worked. So I started sort of tracking them just to see, and sort of maintaining a spreadsheet to make sure that, you know, it's not temporary. You know, also looking at you know, their markers, their LDL, their A1C, their ALTs, all these things. And yeah, so I was, you know, I couldn't believe it.
So okay, so here you are, you're seeing your patients. So they're doing low carb and intermittent fasting, the combination of these two, and you're seeing that the results are powerful. What do your colleagues say? You must work in a clinic with other doctors. They must think you're crazy now, right?
Yeah, well, no, they've heard me talk about Jason Fung many times. I mean, I got 3 of them to read Jason Fung's work, and one of them is actually, you know, implementing this with his patients as well. You know, more along sort of a plant-based diet approach. One of the doctors that actually, she's retired now, but she was handing out you know, the obesity code to people. So some, you know, some got converted in that sense, and they understand sort of there's a physiological rationale there. It's not a crazy diet. It's not a crash diet. It makes sense. In fact, you know, the obesity code, I mean, that's written for GPs, like to my mind. That is like, you sort of need to know something about medicine to understand that book. And a lot of the medications he describes there, the GLP-1s and the SGLT2s, it makes sense why they work by lowering insulin, and it makes sense, you know, with his you know, carbohydrate insulin model, right?
Yeah, absolutely. The both the obesity code and the diabetes code. I mean, these, what Jason Fung does so well is he takes what I call mosaic theory. Basically, he brings in to get, you know, disparate pieces of information together, and he just presents it in a way that makes sense in plain language, right? So I agree with you absolutely. You know, we should give the, you know, the obesity code and diabetes code basically to every resident just to read, just to read and have a different viewpoint. I mean, everybody knows low fat, low energy, every single person, right? But to understand kind of the hormonal basis for some of these is so important. So okay, so now you're evangelizing people in your practice, you're evangelizing, your other people, and I'm just, curious. We've had other doctors from Canada come and say they faced extreme hardship, preaching a low carb message. We've had Evelyn Boudoir Roy come on and talk about that on the podcast. We've had, some, other doctors basically say how they've been, Gary Fedke, Tim Noakes, myself and Brian have talked a lot about that. Certainly Jason Fung has come under heat for his message. At any point, did anybody say you're going to kill somebody? This is crazy what you're doing. Did you face any backlash?
I don't think so. I can't think of an example. I'm not, I'm sort of, again, like I'm very, moderate, I would say, on my advice. Again, it's very minimal, time restricted eating. Now I have some patients who really run with it, right? They'll do the prolonged fasts, they'll do ultra low carb, right? They'll do keto, right? I don't get scared if I see that. Again, I look for certain things. I haven't had backlash yet, but I have had, sort of questions, right? Like out of the patients that I follow, the men do a lot better than the women, right? And I want to know why. Why am I doing something wrong? Are they doing something wrong? Why doesn't this work for everybody, right? I have patients who are, struggling, and it doesn't seem to be working for them. So, I refer them to the weight loss clinic. I refer them to, for gastric bypass, yeah. So I haven't gotten in trouble yet. So.
Got it. Yeah, you're one of the lucky ones. Well, I think now is a different time. So, 4 or 5 years ago when I started delving into this, and even like 2.5 years ago, wow, we're gonna come on. Has it been 2 years or 3 years on this podcast? I don't even know anymore. Initially we faced a lot of heat, but then since then, I know Diabetes Canada was a little more supportive of low carbohydrate carb approaches. The ADA came out, obviously more supportive in 2019. So some of the landscape is changing a little bit. So maybe you just kind of never experienced that, which is good. That's a good thing. A lot of people, have faced that kind of hardship. But yeah, I do see that too. Particularly postmenopausal women, seem to, struggle, and we do see a lot of men. A lot of times we'll have men, the couple come in, and the man loses almost, I don't know, 50% more than the woman.
Yeah.
So have you changed your advice to or how do you advise people when you see something like that?
Well, I mean, I tell them to expect that. I mean, I think most people know men lose weight a lot easier than women. I mean, women certainly do. I think, it's also how much dieting has happened in their past as well. And then I tell them, look, I mean, you don't need to lose a lot of weight to have better metabolic health. You can lose 5%, 10% of your body weight. You can, reverse your fatty liver, and that's where you get your benefit. It's not about, your perfect BMI or to look good on the beach kind of thing, right? You can get healthy before that.
Yeah. It's funny you say that, because I think one of the other things is the expectation, right? If you have a 6 foot tall man, versus a 5'2", woman, right? That 6 foot tall man is going to, one, he has testosterone, so there's metabolic issues at play, hormonal issues at play, and two, he's just taller and bigger. right? And so if you have somebody who's smaller and they'll eat the same amount of food and have two different results, right? They'll have two different results. And I find, and I don't know if you find this, but I'm curious to see what you think, that the pressure on women to lose weight is much more than men. You know, there is an intense societal pressure for women to lose weight and maintain it off. And in fact, you know, sometimes I get these couples that come in and the men don't even care, you know, like they just eat whatever the wife cooks, you know, and they're losing weight, right? And it really, I don't know if I'm overgeneralizing, but I think there's a lot of pressure on women to lose more weight and have a certain figure. To some extent, it's changed now, where you know, those pressures are being put on men. But I think historically, at least, you know, there was a lot of pressure on women. Do you think that those things play a factor?
I mean, yeah, I think they probably do, right? Like, you know, that's the other thing. Like, I look at a patient and I don't even think they're overweight. They don't have diabetes, right? But then when I look closer at their metabolic health, like I have a couple of men that I never thought they were overweight, or they certainly weren't pre-diabetic. But when I looked closer, you know, they weren't optimized, let's say.
You mean like the triglycerides were high and the HDL was low and the vitamin D was low and the what do you mean by that?
Yeah, well, it was just, you know, I had, you know, a couple of patients, again, it wasn't even metabolic health that was their main issue. Well, one of them with pulmonary fibrosis. I happened to check his fasting insulin and it was sky high, his inflammatory markers sky high. And then I thought, you know what, you could lose 20 pounds. And sure enough, he implemented this lifestyle, very low carb, intermittent fasting. His insulin went all the way down. His ALT went all the way down to normal. His inflammatory markers over time, over 6 months, corrected. And then his pulmonary function tests improved by 30%. I couldn't believe it. I was blown away. I have another patient like that, similar. Like it wasn't a weight loss, obesity, diabetes thing. It was back pain from like degenerative discs, and we had an MRI that showed epidural lipomatosis. So fat within the spinal canal that was, you know, causing a functional stenosis, let's say. And he improved the same way with losing the weight, you know, losing 20, 30 pounds. He improved in his back pain. You know, it was amazing. Like I haven't heard about that before. So, you know, again, like I don't know the gender thing. I don't know how you guys manage that, or what do you think about that?
Well, no. I mean, these are amazing cases you're talking about. Let's focus on those for a second. I mean, I certainly think that, well, it sounds like what's going on underneath the hood. Let's look at that idiopathic pulmonary fibrosis case. First of all, idiopathic, guys, just so you know, means doctors don't know and we don't know, right? So idiopathic basically means we don't know, right? So we don't know why. If you hear the word idiopathic, just imagine it actually, what we're actually saying is we don't know why there's pulmonary fibrosis. And pulmonary fibrosis is a fancy way of saying lung, you know, the architecture of the lung becoming more fibrotic, being more stiffened. So here you are, you have somebody who has, you know, idiopathic pulmonary fibrosis. Sometimes we put them on steroids, sometimes, you know, and you see his inflammatory markers are through the roof. You see his insulin's through the roof. And it's not like he's wildly obese, but certainly we know if you take weight off of the thoracic, you know, space, that, you know, he's going to have less restriction, right? So he's going to, his lungs are going to improve. So if you're like, okay, maybe I'll decrease his insulin, decrease his inflammation, put him on low carb, he'll lose a couple pounds. But a 30% increase in lung function, I mean, we don't typically see that with a 20-pound, you know, reduction. So what happened? What happened to him? How did you start him? How did his life change? What did he do? How long did that take? I'm kind of intrigued by this.
It didn't take long, actually, because he really took to the diet and the lifestyle, and Again, I tell people to watch Jason Fung's YouTube lectures and read his books and so on. So within 2-3 months, I mean, he had started losing the weight. Some of his inflammatory markers were still high. And then, I'm wondering if maybe part of it is autophagy, because pulmonary fibrosis has impaired autophagy. So, that's just sort of a question I have. Then he sort of plateaued, and he started gaining a little bit of weight back. We looked at his diet again. We looked at what he was doing, and I'm talking to him like once a month or once every 2 months.
And I'm sure he's exercising too, right?
He's exercising 5 times a week. He's back to cycling, and he's got a respirologist that's following him. He's had this for a long time. They cut out the feather pillows in his environment, right? In his, they're treating aggressively his acid reflux, so that might have gotten better with the weight loss. So it's amazing. Like, I don't know, I never seen that before with this condition.
So guys, just so you understand, the approach to that is you're trying to remove the chronic insults in this guy's, anything that would insult the lungs. And if you go to sleep and have reflux and those reflux goes into the lungs, that gastric content, it's going to aggravate the lungs. And certainly we wouldn't want that. We don't want that in asthma. We don't want that in most people. So it sounds like they're treating this, treating that. They got rid, maybe they're worried about allergic components, those feathers in his pillows, so he got rid of that. And but still, I mean, this is a unique kind of signal. He goes low carb, his inflammation drops, and his lung function improves. I hope I mean, this is kind of a very, very interesting. I hope you guys write it up.
Yeah, I'm gonna write a letter to his respirologist to see what she thinks, because I'm really amazed by his progress. So
I'll be happy to work with you to get that into the literature. I think that's something that we need to do as we see more and more of these things. And then you mentioned your other patient, the kind of the clinical improvement there. I mean, have you seen any other we've heard a lot of allergy symptoms improve. Just anecdotally, we've heard a lot of reflux improve, joint pains. Any other things that you've noticed in this low carb intermittent fasting approach, where people's just symptoms you didn't expect to improve did, or it makes sense if there's fat in somebody's spinal cord and you put them on a low carb intermittent fasting diet, that maybe that fat would shrink.
But I just didn't think that was a place that fat would go, in the spinal cord. That's an odd place for it to be deposited, right? Like,
it is. Absolutely.
I mean, these are sort of my star patients that I've had, that I followed. And again, I maintain this, some people, they lose the weight and then they go back to the old ways, they regain the weight. It's just like anything else, right? It's, I go back to my spreadsheet and I update it, and, somebody lost, 8 kilos. Now it's actually, they regained it all. So, it's a process for sure.
Yeah, I mean, so I think that's the other part, right? I know in the Canadian model that there's different, there's a little bit more restriction in terms of what you can and can't do. We can actually see some patients very frequently, text them, email them, engage them in group meetings and stuff like that. How do you keep your patients engaged? I mean, I'm sure you've seen, like with anything else, in this modern food environment, what's most likely the thing that's going to happen? People are going to regress to that modern food environment, right? So how do you keep, I mean, it sounds like you've already seen much of what we've seen, which is, sometimes people fall off. How do you, how do you reach out to those people?
Well, I mean, if they're diabetics, right? If they have diabetes, they're supposed to follow up every 3 months or 6 months if they're well controlled. So I see them periodically through that, right? And then just through general, follow-ups. Now, in the last year, we're doing a lot more video calls and phone calls and emails and things like that. So it's easier to keep in touch and touch with people. Yeah, and I would say the volume is the exact same as before. How do I keep them from the modern food environment? I mean, it's been easier since people are at home more and they're not celebrating with family for every holiday and they're not feasting all the time. A lot of people find it easier to maintain this diet. And even some people who, for example, with alcohol use, right? Some people who are trying to quit their alcohol use, it's been much easier for them to do that now since everyone's isolating and staying at home.
Yeah, I've seen that split. It's funny that you mentioned that. I've seen a pretty clear split. The people who had the mental drive and were socially driven, right? Were like had that social drive to eat and drink. Those people have improved, where they couldn't fight. They have an internal desire, but those external pressures really were kind of messing with it. The other side that I've seen are people who are just stressed out, have mental health issues, stress issues. They've like delved back, right? They're just stressed out people looking for comfort. And the easiest comfort in our homes is food, one, and then two is the alcohol. And we've seen this across the board, this like kind of split, where you have those people that have lost who have gained no weight, and it improved, during COVID. And then there's people really suffering. And that's why we've tried to bring people in a community format, to kind of, we all need that support, at different times. So that's interesting. Okay. So, as, you've gone virtual, I'm sure, I'm curious, have patients come to you now they know you do low carb, now they know you kind of focus in on diabetes and fasting? Have they asked you how tough is it to get a patient a continuous glucose monitor in Canada? I'm just curious.
I have a type 1 diabetic that managed to get one through the Dexcom, through his endocrinologist and insurance. We have this Freestyle Libre, so that's available. I don't know. I haven't really gotten that on. I haven't really pushed for that. I don't know.
Got it. We have, because I can't tell you how many patients we've had contact us from Canada. They're like, can you send us, Libres? And I'm like, no, we can't do that. We're not licensed, because from what it sounds like, it's very tough to get a hold of a CGM, maybe because of insurance or something like that.
I think you can buy the Freestyle Libres. You can just buy them, right? But they're expensive. Like they're those sensors are expensive, right? That you apply, and also from what I hear, they're not that accurate. So
for somebody like your dad who may or may not inject insulin, we always have them confirm. They're plus or minus 20, but it looks like
20%,
well, 20 milligrams per deciliter. So for you, that would be, I guess, half a millimolar or so, roughly. But for like the hobby, the pre-diabetic, diabetic, to see the impact of the, the rice and the bread that we're told to eat, the whole grain rice and bread, that's it shows that pretty nicely.
Have you found that useful with your patients? Like, is it motivating for them to see that?
Hugely motivating, right? To see. And here's the other thing, why should they trust you and me? Why should they trust you and me when we say don't eat that way, right? If the guidelines have said eat, whole grains, and if they've been told that by a plant-based proponent that eggs will cause diabetes, right? So why should they trust us? Or butter is good, or butter is bad, or eggs are good now, or eggs are bad. Why should they trust us? So I found that it's an immediate feedback. Here you go. If you have diabetes, go eat eggs and let me know what happens to your diabetes. Go eat, use almond flour instead of flour and let me know what happens to your sugar. I think it's a way, and it also gives the patient immediate feedback. Like, how am I doing? How stable are my sugars? Versus, having to wait for a scale that could take weeks to really drop. In some cases, that postmenopausal woman you were talking about who struggles with that weight loss, but to see that they're on track and their blood sugars are in a good place, and to see that in real time, I find it valuable. But you're right, it's expensive. It's 35 bucks a sensor. I think Canadian,
how
that's
long
like 40
how long
bucks.
how long do they keep using it?
Oh, on average, our average user probably uses it a month to 2 months.
Okay.
And then there's very little utility after that, right? If you're not a severe diabetic, right? If you're a severe diabetic, there's a big utility. Some people like that instant feedback too, to be able to see how they did today. Right. It's tough, when you get on the scale and just because you're a little constipated and you ate a little bit of salt, you're holding on to more water and more stool, right? The number says you did bad. Right. But when you look at that CGM and it says, wait a second, you did good. I think that's a powerful, that feedback is powerful. We've had a lot of, I mean, is it cost effective? No. I mean, if I was in Canada, they'd probably, put me in the, I don't know, what do they have? They'd say, excessive prescription writing, whatever. So, have you found that your referrals to the weight loss clinic have decreased, after you've kind of?
I mean, they haven't. I mean, some of my patients, the more difficult ones, they've been to the weight loss clinic. They've been for a gastric bypass surgery assessment, and they said no, and then they end up going back. Like there's some cases that are really, really hard, so I will send them, for example, or prescribe Saxenda, right? Saxenda and hopefully Ozempic soon enough, right? That seems to work. That seems to get people going for some cases.
Yeah, I'd say we have like a 5% rate of prescription drug use or or referral to gastric surgery. I mean, there's certainly some people that benefit. Yeah, the GLP-1 drugs are probably the best in the bunch for diabetes. If somebody has weight to lose and they have diabetes, I have a very low hesitancy. Obviously, if they have a thyroid issue or, if they're heavy drinkers, I very rarely prescribe it, because of that pancreatic inflammation. But I like them. They give people fullness. I think it's a real effect if you have somebody who's really good at low carb. I don't think there's a huge effect, right? But the people who really benefit are the ones who get the nausea.
Oh yeah,
You know what I mean? Like if you're nauseous, you don't want to eat. It's like a fasting aid, I guess, to some extent, right? I've had a nephrologist from Canada actually tell me, a good doctor, he told me that he got a sense of fullness he never otherwise got, though. Yeah. So this has been great. This has been absolutely great. And thank you for coming on. If people are listening to this podcast and they have an interest in kind of finding you, how would they get in touch with you?
I have an email address that they can email me at. I'm not looking to find more patients because I'm pretty busy with my practice.
Well, any upcoming projects in your practice? Maybe, hopefully, we can convince you to evangelize further, get some of these case reports in the literature, because that pulmonary fibrosis case sounds very, very interesting. And the reality is we don't have, we don't have enough data. We don't have enough clinical data. So it'd be nice to see those things happen. So you're not looking for patients, but anything else to expect from the good doctor?
No, just hoping to keep learning from you guys and hoping to see medical education change. I think, as you said earlier, the guidelines are slowly changing. and hopefully the education will change. I mean, I think society is slowly changing as well. Like, I mean, you can go to Costco and find low carb keto treats and things like that. So people can easily substitute these days, whereas, you know, even 2-3 years ago, they couldn't. So yeah, it's very exciting to see this change in paradigm, right? And just a improvement in people's health, right? They can take ownership over their own health and get healthier, right?
Giving them hope and a way, right? Not just a hope and a way to achieve, reversal of metabolic syndrome and diabetes and maybe some weight loss, and in one case, pulmonary fibrosis, which is, I'm still amazed by that. That's amazing. You have to publish it. I'm going to get you to promise me right here.
Yeah.
Okay. We're going to publish
it. If you help, yeah, absolutely. Yeah.
Okay. You know what? That's a deal. I'll help you out. I'll get you, maybe we'll get an interested med student, and myself will work together. We'll put it out there.
Yeah.
This has been great. Thank you so much. And I guess you're not looking for patients, but anywhere people can, are you on social media? Are you active on social media or anything like that?
No, I'm not.
Not really.
No,
You're just like a good doctor. You're not like us showmen here. You're a good clinician. Listen, thank you so much for coming on. And any friend of Jason Fung is a friend of ours.
Yeah, thank you, Tro. Thank you so much for having me.
All right, have a good one.
This is great. Yeah, you too.